Good afternoon and welcome everyone. I'll ask you to take your seats, or if you're grabbing your lunch, try to do it quietly. Welcome to the CAHR Symposia, the Art of Managing HIV Hepatitis C Co-infection in the Era of New DAAs. DAAs, of course, is direct-acting antivirals. There's been tremendous progress in what we can offer people living with hepatitis C and what we can offer those living with HIV hepatitis C. And the progress has come at such a breakneck pace that it's very difficult to stay up to date. Now, thankfully, there are two ways that you can be completely up to date on the state of art with co-infection management. The first is to stay for the next hour and a half and listen to our outstanding panel, who are all experts in their fields of co-infection. And two is to check out the Canadian co-infection treatment guidelines, which will be available in print with the Canadian Journal of Infectious Disease and Medical Microbiology within the next 2 weeks. So look for that. I first off would like to thank Merck for their generous support of the activities today. This program has been accredited, and the program is a co-infection talk. We're not specifically favoring any compound. We're here to discuss the facts and the best management for people living with co-infection. Please complete the evaluation forms on your table. That'll be very helpful in planning future symposia and other activities that we do at CAHR. There are cards on your table. There will be time for questions after the speakers have spoken, but we'll save it till the end. You can either ask from the audience, there'll be a microphone going around, or if you're shy, then you can fill out the questioning card and it'll make its way up to the front, and we'll try to answer as many of your questions as we can. So, without further ado, I'm Dr. Curtis Cooper. And by the way, the faculty information was up on the board, and I'll introduce each of our faculty as they speak. I'm Curtis Cooper. I'm an infectious disease specialist from the University of Ottawa, and I've been providing clinical care and been conducting clinical research in the field of co-infection for a long time now. There's learning objectives, of course. The first is to identify important drug-drug interactions that apply to co-infected patients, to identify the impact of liver health in co-infected patients, and to drive the use of tailored antiretrovirals and direct-acting antivirals for long-term success of your patients. This is our agenda. And again, we're accredited. So, I thought it'd be nice to start off with a case, just to set the table and to remind us of all the key issues that we need to consider in people living with HIV hepatitis C co-infection, and to remind everyone it's not just about the drugs, it's the whole patient, and there's many things to consider. These are my conflicts. As you can see, I work with everybody quite happily. So, the case is a 45-year-old male, HIV hepatitis C co-infected. His risk factors for exposure to HIV and hepatitis C was injection drug use, and he's still actively using. There's a past history of alcohol excess use. Now he occasionally goes on a bender. Okay. As far as his HIV treatment, he's on efavirenz, emtricitabine, tenofovir, and he's been on that for 6 years. He usually takes his antiretrovirals religiously, except when there's interruptions, when he goes on a bender. CD4 counts 450, and his HIV viral load is currently fully suppressed. He likely was infected with hepatitis C in his early 20s. It's often very difficult for people to pinpoint the exact time when they were infected with hepatitis C. He's As you know, hepatitis C comes in different flavors. They're called genotypes, and that matters as far as selecting the appropriate antiviral therapy for each genotype. This patient has genotype 1 infection, which is the most common genotype in Canada. About 70% of people living in Canada are infected with genotype 1. Viral load is a little bit over, or close to 1 million copies. He did receive pegylated interferon and ribavirin in about 10 years ago, but he interrupted this after 6 weeks because of poor tolerance, and he also had a relapse into excess alcohol use. He did have what we would consider a good virologic response to therapy. His viral load dropped 2 logs at week 4. Okay. He had a liver biopsy done long ago, 2006. It suggested that he had stage 2 fibrosis. Recall that we evaluate fibrosis on a scale of 0 to 4, where 0 is no damage in the liver and 4 is cirrhotic. And once a person is cirrhotic, that's when they're at risk for liver failure and liver cancer. So he has enough scarring there that we should be talking about antiviral therapy for sure, but he's at no critical risk right now. Keep in mind that biopsy result may have been influenced by the fact that he was consuming far much more alcohol then than he is now. He hasn't had a Fibroscan yet, but a calculated APRI, which is based on liver enzyme measure and platelets, suggested that he was in the mid-zone for fibrosis. The patient uses marijuana every day, and he also frequently takes liver cleansing remedies. Okay. He uses a long-standing use of a proton pump inhibitor, which he uses when he needs it for reflux. So the patient arrives and he says, "I want therapy now. I've heard that there's this great stuff. Give it to me now." So these are key questions that we're going to consider. Keep these in mind as we listen to our speakers. What are the direct-acting antiviral treatment options for a co-infected patient these days? What are the drug-drug interaction concerns? What is the best fibrosis assessment modality? What about reinfection risk? Should that influence our decisions about offering treatment or not at all? And are hepatitis C treatment outcomes really as good in co-infected patients as they are in hepatitis C monoinfection? Remember, in the old days with interferon and ribavirin, the cure rates in a co-infected patient were much less than in mono-infected patients. So with this in mind, I'd like to ask Dr. Brian Conway, who's the President and Medical Director of the Vancouver Infectious Disease Center in Vancouver, to come and give us the goods on direct-acting antiviral therapy. I've known Brian for a long time. He's one of the very first Canadian physicians to offer hepatitis C treatment to co-infected patients decades ago. So I can think of nobody else who would be better to give this talk than Brian.
Okay, thank you. Thank you very much, Curtis. I'd like to echo our recognition of Merck for sponsoring, supporting this non-partisan event, and I thank the organizers for allowing me to speak with you here today. These are my disclosures, not as many as Curtis, but I'm working on it. And over the next 15 minutes or so, I think I'd like to address the issue of what populations are co-infected, understanding the epidemiology of HIV and hepatitis C co-infection in Canada, to discuss the major therapeutic advances that have occurred over the past few years and are available to our patients in order to cure the hepatitis C, not control, not make quiescent, not make dormant, out-and-out cure. This is a curable viral infection. And perhaps just as important, to understand the context in which this treatment should be administered, not only to maximize the success of achieving a cure, but preventing a recurrent viremia or reinfection after a successful cure has been achieved. This is a universe of chronic viral infections in the world that affect significant numbers of millions of people, namely hepatitis B, hepatitis C, and HIV. And the population on which we will focus today is those who are co-infected with HIV and hepatitis C that number between 12 and 15,000 in Canada. Now, this is not a random subset of individuals who carry hepatitis C in itself and HIV in itself, but it really is affecting a very selected subpopulation of both infections. If we look at individuals who have acquired HIV by various means, we note that fully 80% of HIV-infected injection drug users are also co-infected with hepatitis C, and this is significantly higher than the 30 or 40% or so that one would find in a general HIV clinic, and higher yet again than a population that would be made up exclusively of men who have sex with men. So as we consider HIV and hepatitis C co-infection, we will be largely focusing on more vulnerable, disengaged individuals for whom probably different models of care will have to be developed to ensure that they can benefit from the treatments that we will be discussing. So how do we begin to access this population? Well, obviously the first step is to test people and find out who is infected and who is not. It is said, according to American data, that as many as 2/3 of people who are infected with hepatitis C are unaware of their diagnosis, and that this number might be a little bit higher even in the setting of HIV co-infection, where hep C testing is not universally done or recommended. So without debating whether we should be doing one thing or another, I think we would all agree that in the HIV population, testing them for hepatitis C, doing an antibody test, and then doing a test for viremia to rule out the spontaneous clearance that occurs in 20% or so of the population is something that would be indicated. Now, in those who we find to be uninfected, this affords us a unique opportunity to intervene to prevent them from becoming infected by implementing various harm reduction and counseling strategies, encouraging safer injection and drug use practices, and other types of intervention to prevent sexual transmission, let's say, among men who have sex with men, which is occurring in certain areas, to prevent them from being infected. And in those who are already infected, these interventions are probably also appropriate to prevent onward transmission of infection until we set up the strategy to make them benefit from the treatments that are available. Now, it's not widely known, or at least surveys tell us that it's not universally known, that hepatitis C can be more easily treated and is curable. So I think this is also information that we need to get out there to encourage proper referral of individuals into care so that the treatment modalities can be properly discussed. And the benefits of treatment are really twofold. First, to the patients themselves, to prevent chronic liver disease, end-stage liver disease, cirrhosis, and hepatocellular carcinoma, so to stop the progression of liver disease. And also, we think that especially if we intervene on people who are so-called core transmitters, individuals who will be still transmitting the virus or actively using drugs, for instance, that by treating those individuals preferentially, we may, in some measurable means going forward, reduce the prevalence and incidence of hepatitis C, especially in the co-infected population. So this all is a very nice story, and it really begs the question, why haven't we considered treatment previously? Well, the first versions of hepatitis C treatment, interferon injections alone, administered several times a week, were producing cure rates that were below 10%. With the once-weekly interferon, the cure rates rose, and adding ribavirin in combination with that produced better results, but still, at least in the co-infected population, these success rates barely passed the 30% mark. So what we would be doing is asking someone to receive an injection once a week for 24 to 48 weeks with significant side effects, to take pills on top of that with additional side effects such as anemia, with a 7 in 10 chance that the treatment wouldn't even work. So it really wasn't an attractive proposition, and it is really with the advent of the all-oral, directly acting antiviral agents that we could include treatment in this paradigm of diagnosis, engagement, and care, and trying to cure hepatitis C. So Anu Osinusi and others in the Washington, D.C. area embarked on this very heroic study called Eradicate, in which individuals who were infected with HIV and hepatitis C were offered the opportunity to receive a single tablet, the NS5A inhibitor ledipasvir, the nucleoside analog sofosbuvir, given as a single tablet, known as Harvoni now. So they studied 13 individuals who did not qualify for HIV treatment because their CD4 cell counts were too high. They were true long-term non-progressors. And of those 13 that received one tablet once a day, all were cured. Of 37 individuals on various forms of HIV treatment, same model was applied. They were stable, suppressed viral loads, given one pill once a day for 12 weeks, and 36 of 37 were cured. There was one individual who was found to have virus 36 weeks after the end of treatment, whether that's a late relapse, an early reinfection. Still, the success rate of 97% must be thought of as quite impressive. These data were replicated in a large clinical trial, ION-4, in which the combination of ledipasvir and sofosbuvir was administered for 12 weeks in genotype 1 and 4 co-infected patients, and overall the success rate was 96%. Now, one sees that the success rate was equal whether the person was naive or experienced, whether they had little scarring in the liver or were frankly cirrhotic, or even if they were both experienced and cirrhotic. The only group accounting for 12 of the 14 failures in which a slightly lesser efficacy was observed was in the black subpopulation. Now, whether this is due to unmeasured predictors of poor response that aren't captured by treatment history or liver fibrosis, factors of adherence or others, is still not yet been completely elucidated. But even in this population, you're at 90% success rate. So going to other combinations that have been studied in the setting of co-infection, the combination of the protease inhibitor grizoprevir and the NS5A inhibitor elbasvir was studied in the CAHR co-infection study. And here again, we have success rates of about 95% of cure, 207 out of 218. This was true in genotype 1A, genotype 1B, and genotype 4. There were 11 treatment failures. One was a frank reinfection, 4 were lost to follow-up, and only 6 true virologic failures. Not shown on this slide, but I can tell you that there was no subgroup identified in which an inferior response was demonstrated. Of the virologic failures, there were resistance mutations detected in 5 of 6, suggesting that these were true failures of the virologic regimen. In terms of the HIV side of the equation, there were no sustained virologic breakthroughs. There was no decrease in CD4 cell counts. There were no patients discontinued due to adverse events, and there were no serious treatment-related adverse events. So this is a very good news story, again, of one pill once a day for 12 weeks that produces this success rate in the setting of co-infection. Now, the other treatments that are available to us, the combination of paritaprevir, the protease inhibitor boosted with ritonavir, along with ombitasvir and dasabuvir, the so-called 3D or PROD regimen, depending on how you wish to refer to it as, produced very good success rates in a small number of patients that have so far been reported on in the turquoise study. You will see in orange giving 12 weeks and in blue giving 24 weeks. There's no difference in prolonging treatment, and the success rates remain very high. Now, while we await the results of larger clinical trials or the continuation of this clinical trial going forward that's fully enrolled and will probably report within the next year, it's reassuring to see real-life data presented from a number of Italian infectious disease clinics recently presented at an international liver meeting. This was 204 individuals, the vast majority of whom had full virologic suppression of their HIV. At end of treatment, 202 of 204 had suppressed viral load, and of the 193 in whom data on cure are available, the cure rate is a very impressive 97.4%, with the 2 previously mentioned breakthroughs along with 3 relapses. So there's at least 3 ways in which we can treat our HIV-HCV co-infected patients and achieve very high degrees of success. Now, how are we going to do this going forward? We in Vancouver have developed a model of what we call the 4-legged chair, in which we provide the medical treatment for hepatitis C, but we deliver it in a proper context, addressing individuals' other medical needs, trying to address their psychologic or psychiatric needs, making sure that addiction-related issues are addressed, and also making sure that social issues such as availability of government funding, availability of better housing, food security, legal issues are addressed all under one roof. So we're trying to use the medical system as a tool of social change, focusing on engagement in care and offering the hope of curing their hepatitis C and addressing many of their other needs at the same time. And I would encourage you to visit the poster area after this session, since our group has a number of posters that describes this model in greater detail. So in this analysis of 40 active drug users that we have treated, and this is work that was done by Arshia Ali Mohammadi in our group and has been accepted for publication. These are 40 active drug users using heroin, cocaine, and the other being mainly crystal. This work was largely done in the pre-fentanyl era. The distribution of genotypes is about 60% genotype 1, 30% genotype 3, 10% genotype 2. So the distribution of genotypes that we expect. Our success rate overall is 78%, a very impressive 68% in interferon-based regimens, and curing 14 of 15 individuals who received all oral regimens. And the individual who failed on the all-oral regimen is an individual who had genotype 3A, a very high viral load, cirrhotic, and had previously failed a number of courses of treatment, and in whom, if anyone will fail, this is a type of patient that will. Now, going forward, we followed this cohort for an average of a year and a half, going on 2 years, and to date, we have not experienced any recurrent viremia. And we feel that this absence of reinfection relates to the comprehensive nature of the program that we have developed. Now, this is not to say that we have not seen any reinfections. Our rate is somewhere between 1 and 2 per 100 person years, but it really is an issue that needs to be seriously considered in treating the co-infected population that will be largely made up of injection drug users. Now, not to preempt the presentation that Pierre Giguère will make in a few minutes, but in preparation for putting patients on their hepatitis C treatment in the setting of HIV co-infection, we need to consider the optimal, let's say, HIV treatment that they should be receiving. And one factor to consider is the minimization of drug interactions. And you will see that the lines that appear in light blue all the way across horizontally are represented by the 2 unboosted integrase inhibitors, namely raltegravir and dolutegravir, and it's at least a consideration to get patients on this form of treatment for their HIV so that it will minimize what we need to do when we start treating the hepatitis C. With respect to the hepatitis C treatments, there is potentially an interaction between ledipasvir and sofosbuvir that must be considered, or ledipasvir and tenofovir, that must be considered in the setting of co-treatment using these molecules, watching renal function. And if one uses the PROD regimen or the 3D regimen of AbbVie, consideration must be given to the fact that you are adding ritonavir to the regimen, which creates drug interactions in and of itself, and would need adjustment of the antiretroviral regimen if it already contains ritonavir, so that we aren't double dosing ritonavir in effect. So in conclusion, I think that we now know that we can use the same regimens in HIV co-infected patients as in HCV mono-infected patients to achieve the same positive results. This probably applies to active drug users, perhaps a bit more so in those who are in opiate agonist programs, and I would encourage you to visit a poster, the CAHR COSTAR study, in which we have successfully treated several hundred active drug users for their hepatitis C, and look at the parameters that led to these results of SVR in 95.5% of cases. The drug interactions must be considered in terms of selecting treatment, both with respect to ledipasvir, tenofovir, and things such as that, and the use of unboosted integrase inhibitors for treatment of HIV to facilitate a smooth transition to Hep C treatment. Thank you very much for your attention.
Great. Thank you very much, Brian. So it takes more than just a physician to successfully manage hepatitis C, HIV, you need a multidisciplinary team. Brian has very eloquently laid that out. In Ottawa, we've had the good fortune of having Pierre Giguère in our HIV clinic, and in the last several years in our viral hepatitis program as well. And he has, on more than one occasion, saved patients from my misdeeds. He's been managing drug-drug interactions in co-infected patients for almost 20 years now. So he's the perfect person to talk to us for the next couple of minutes about the important drug-drug interactions that we need to be on the lookout for as we treat hepatitis C.
First of all, I think that Curtis has been a bit too generous in his comments. I haven't saved so many of his errors in the past few years. But I'm honored to be here and give this, what I call an impossible task, to present drug-drug interaction summary on HIV and HCV co-infections. I think that doing this over 15 minutes is a bit too short, but on the other hand, what I will try to do is maybe give you a bit an overview about the mechanism for drug interactions, and maybe highlight it with 3 different examples so that we can see that drug interactions can occur with DAAs and how to manage them. So these are my disclosures. So as I said, in terms of objectives, the goal is to recognize and understand the management of clinically meaningful drug interactions in HCV. We've picked here 3 different topics. The first one, I think, is obvious. It's about antiretrovirals. This is a presentation about HCV, HIV co-infection, and there are multiple drug interactions, as alluded by Brian earlier. We'll talk a little bit also about acid-reducing agents, because it seems to be a common class of medication used in our patients, and also talking about psychotropics. I'll try to propose a stepwise approach to how to address drug interactions, and also provide you with some resources on the web to help managing those. So this slide essentially highlights how common are drug interactions. This is not the latest one. At EASL, there was another poster presented about how common these drug interactions occurs in co-infection. But in this slide, if you look at the lower part of the left panel, what you can see is, depending on the different drug regimens, there can be up to 60% of potential drug-drug interactions. Fortunately, these are not all serious drug or severe drug-drug interactions, but at least a good potentials for moderate drug interactions. On the right hand side of the slide, again, this is just looking at the patients on sofosbuvir, ledipasvir, and saying that in about half of them, there's no significant interactions expected. However, the other half needs to have some corrections of their either antivirals or antiretrovirals or DAAs. The link of these drug-drug interactions in clinical practice in HIV-HCV co-infection does not exist. So what we have, the closest information we have is about HIV patients. When we look at the prevalence of patients being on drug interactions that are, not drug interactions, but drugs that are contraindicated, this is in blue here. What we can notice is that there is a higher proportion of patients that will be admitted to hospital in the first year following the start of the combination antiretroviral therapy. As I said, unfortunately, we have no such data for DAA use in terms of drug interactions. However, looking at this slide, I think that the same conclusions may be applied with regards to what are the variable that are also correlated with this fact, having a lot of comorbidities, and also using drugs like protease inhibitors that can lead to several drug interactions. So drug interactions can be explained in three different ways. And in this cartoon here, what you can see is that the first one is essentially is in terms of absorptions with regards to the solubility of drugs. Some of the medication needs to have a low pH for a good absorption, and therefore any drugs that will alter this pH dependent or the gastric pH will have an impact. There's also something that pharmacists love to talk about. It's about drug interactions in cytochrome P450. I've listed many of them there, but these are important ones. And in the era of the new DAAs, we have a bit of the protease inhibitors that could, at some point, have an impact there. Unfortunately, the NS5A doesn't have much in terms of metabolism, so that spares a little bit the work of pharmacists. The new thing, we call it kids in the block, is about drug transporters, and this is something that we're learning as time goes by. We've learned that drug transporters like P-glycoprotein or other ones listed here on that slide can alter the way the medications are going to be distributed in the system. So these drug transporters are located in your GI tract, they're located at the entry of your brain, and they regulate which drugs are allowed or not allowed. On this slide, I've kind of oversimplified the way the drugs can have drug interactions. So on each of the row, you'll see the name of the different options we have to treat hepatitis C now. And then the first, I would say the HCV drug metabolism is essentially how the drugs are being metabolized or disposed in your body. And you can see that no matter which drug you're thinking of here, there's either some metabolism drug interactions, like in the case of the 3D regimen by AbbVie, but there's also a lot of drug interactions that can, or the drug interactions that can be due to drug transporters. On the right-hand side on the slides, you can see what the drugs can do to other drugs, essentially leading to drug interactions with other concomitant drugs. And again, you can see here that with the 3D regimen, there seems to be a little bit more drug interactions in terms of the metabolism of the drugs, but on the drug transporter sides, many of these treatments have also impacts on drug disposition. This is an adaptation of the extended table, which is available in HIVclinic.ca or hcvdruginfo.ca. This is a site maintained by Alice Tsang in Toronto. And here, it's quite of a complicated table to go through. But the way to read this is everything in green is okay, and we don't expect any drug interactions with the different drug options. In yellow are the ones that we have to pay some attention, that could probably be managed, but we have to maybe adjust the dose. And in red are the ones that we should not co-administer. So the easy way to look at this is maybe to look from up and down. And what you can see is that there's some of the regimens there that no matter what you give in terms of antivirals, that it has minimal impact, like sofosbuvir, for example. There are other therapies that contains more protease inhibitor-based, which are the two last columns on that table, whereas there is a greater potential for drug interactions. If you read it the other way around and you go by row, what you can see is that there's some HIV therapies that are much more friendly with our hepatitis C drugs. And drugs like rilpivirine, like raltegravir, like dolutegravir are likely going to have a minimal impact on the pharmacokinetics of the hepatitis C drugs. This seems very simple. You see it like a 2x2 tables. HIV therapy is not as easy to treat, and there are many times where you have to give several drugs. And what is the result of combining two interacting drugs together? Are they going to cancel out or have a greater effect in terms of their in terms of the interaction? That is unknown. So I think that this is maybe a very simple way to look at the drug interactions. I would like here to highlight the tenofovir interactions with lidipasvir, sofosbuvir. This has been drawn a lot of interest lately. And the way to read this slide essentially is that we know for many, for our HIV patients and co-infect patients, what is the normal range of exposures of tenofovir? So the average concentration, serum concentrations of tenofovir. And this is expressed in this slide in the gray zone. What we've noticed when we did drug-drug interaction is that some of the patients that will receive tenofovir along with ledipasvir, sofosbuvir, and in this very example here, we talk about atazanavir, ritonavir, and darunavir, ritonavir. So essentially, treatment that where we use a booster is that the tenofovir exposure is a bit increased in some of the patient, not in all of the patient, but in some of the patient. And we are lacking safety data with that range of exposures of tenofovir. And I think, as Brian just said it, that raises a concern as if there's too much tenofovir in relation with what we usually see in other patients. Does that mean that there's going to be an increased risk of toxicity? And I think I agree with his recommendation that for these patients, maybe it's important to increase monitoring. At the bottom of the slide here, I've added two. I mean, people know about TAF, which is tenofovir alafenamide, which is a new version of tenofovir or TDF. One of the common, what we know about TAF is that there's a very low exposures of tenofovir, as illustrated here in this slide. And with TAF, it seems that the interactions with ledipasvir, sofosbuvir would probably not lead to any clinical problems. Talking about PPIs or acid-reducing agents, here the table is just highlighting the drugs that we believe that may cause problems. We have, you see that there's a lot of green on this table, except for ledipasvir, sofosbuvir, which has drawn some interest lately. We know that there's about a 40 to 50% decrease in ledipasvir serum concentrations when we use it along with PPIs, and that there's a recommendation to limit omeprazole to a maximum of 20 milligram daily, giving at the same time as the DAAs. You will notice that the same thing seems to be true with the new drug that we haven't talked about yet, which is velpatasvir. It's coming out probably in the next few months. And the decrease in the concentration of that new drug is also affected by omeprazole. So there are ways to manage this. We've been doing this very successfully in our clinic. However, in the fall, there was a clinical trial showing that there was a 5% decrease in response rate. This is from the target cohort in patients using PPI versus those not using PPIs. This information was a little bit, controversial. And at EASL last month, there were 3 papers, and these 3 papers essentially were not able to confirm the results observed with the ones in the target cohort. So the TRIO network was unable to see a difference. We did the same analysis in our center in a much more restricted number of patients, and also we were not able to detect a difference. And there was a pharmacokinetic study in decompensated patients using low-dose PPI and ledipasvir, sofosbuvir, and again, they were not able to see the difference. Very quickly here, because I'm going to be running out of time soon, and Dr. Cooper will be reminding me. The drug transporter is something which is quite interesting. What we've noticed over time is that these drugs, as I said earlier, they're kind of regulating how much drug is getting through a barrier, like the blood-brain barrier, for example. And these drugs, as the development of new drugs are taking advantage of that. And one of the common examples is the Benadryl. Everybody knows that Benadryl has a lot of sedation and cause grogginess, and this is mainly because the drug can get into the CNS. However, the newer drugs like cetirizine have been shown to not go into CNS because the PGP is able to pump out these medications out of the brain compartment. And there's been several case reports showing toxicity of drugs when you co-administer these drugs with inhibitors. So what we do in to prove a little bit that is in this experiment where they took mice and they genetically decrease their ability to use PGP. So essentially, they're knockout mice with no PGP activity. And here what you can see is that that big bar, which is risperidone, you can see that there's a lot of 60 times more drug getting into the CNS because of that, the PGP was not effective. So this mimics a little bit what can happen if we give a drug that would interact. So in the last minute, I'm going to give you some strategies about how to address DDI. So the first important step, I think, is to make sure to complete a very thorough medication history. This slide came from I think Dr. Back in Liverpool, who said, always be aware of the unexpected. Don't take for granted that just the medication profile is good enough. Talk to the patient to see what they're using. Consult good pharmaceutical resources. I'll show you which ones I recommend at the end. And at the end of the day, the question is, how to make the interpretation of these data? So I think the easy ones are the green and the red ones. So the green ones are the ones that we expect nothing, and therefore we shouldn't be too much worried about. And the red ones are the ones that we have a very high suspicion rates that something wrong is going to happen, and therefore we shouldn't be using them. The orange ones are the ones that are more complicated, and here one of the way to address this is to assess, is the drug necessary? And if it's not necessary, let's stop it. And if it is necessary, maybe we can switch it to something safer. So these are the kind of management that can be done. And in our clinic, what we do most of the time is just to establish a good monitoring plan to make sure that we're not missing something important. So the last slide is about the online resources. I'd like to draw your attention on this new tools that I'm a bit biased because I'm a collaborator with Alice Tsang and Michel Foisy. But this new tool that was released last month, which will make HIV and HCV drug interactions kind of summary. It's a very friendly tool. It is available as a poster, so I encourage you to stop by and talk to Michel about this tool. It also has information about important information like can we crush these drugs, what are the formulations, and so on. So this is a very comprehensive tools. And there are two other online resources that I highly recommend. Everyone in the field knows the Liverpool website, the hepdruginteractions.org, that has been re-engineered lately, and I think that they've made a great progress. It's a great tool. Et pour nos patients francophones, et pour nos traiteurs francophones, Rachel Terrien de Montréal a un excellent site qui s'appelle le guide thérapeutique VIH.com qui aussi peut offrir ces ressources. Very, very quickly, I'm sorry, I forgot last one. But the red flags, keep in mind about these antivirals. There are some drugs that we're more worried about. We're talking about anticonvulsants and some of these other drugs. And also maybe increased pharmacovigilance for some of these drugs. I didn't talk about the statins there, but they're the ones that we have to pay attention to. On this, thank you very much, and I'll give the microphone to Curtis again.
Great, thanks, Pierre, for thorough coverage of a critical area of co-infection management. So it's now my pleasure to introduce all of you to Giada Sebastiani. She's an assistant professor of medicine at McGill, a hepatologist, and a world leader in fibrosis evaluation. It's important to remember that once hepatitis C is cured in our co-infected patients, it doesn't mean that everyone is scot-free. Just like everybody else in the world, there are other liver conditions to be concerned about that we need to monitor for, and Giada is going to make sure that we're able to do that. Yeah, so welcome. Thank you.
Thank you very much, Curtis, and I really would like to thank the organizers, the chairman, and my colleagues for the kind invitation. So these are my disclosures. And these are the objectives of this lecture. So the epidemiology of HIV has changed significantly in the past years. As you know, given the introduction of the highly active antiretroviral therapy, the causes of death in HIV-positive population has changed. These are the data from the Canadian co-infection cohort from Dr. Marina Klein. And as you can see now, the first cause of mortality in co-infected patients is end-stage liver disease. Indeed, the proportion of deaths caused by liver disease increased 8 to 10 times in the post-ART area, while the AIDS mortality has fallen 90 times. And one thing that is very important to remember in our clinical practice is that chronic elevation of transaminases is very common in patients chronically treated with antiretroviral therapy. These are our data which show that in HIV mono-infected patients, so even those without co-infection with hepatitis C, chronic elevation of transaminases is quite common. Is about 15% of patients you find elevation of transaminases. And this elevation is even more common if we take patients with metabolic comorbidities. These data are from about 1,000 patients in our clinic. So ARV, antiretrovirals, I think I always saw them as Dr. Jekyll and Mr. Hyde. For sure it's Dr. Jekyll for HIV doctors because it changed dramatically the mortality cause in patients with HIV and has prolonged dramatically the life expectancy. But for hepatologists like me, could also be seen as Mr. Hyde for a number of reasons that I would like to show you to you. So as we said, up to 20% of HIV-positive patients on ARV have elevation of liver enzymes. And risk factors include the baseline elevated transaminases and co-infection with hepatitis C and with hepatitis B, and also the use of concomitant hepatotoxic medication. The three classes of drugs which are mostly associated with hepatotoxicity includes protease inhibitors, non-nucleoside RT inhibitors, and nucleoside RT inhibitors, and these have been associated with significant hepatotoxicities in a number of studies. And there are a number of mechanisms of ARV hepatotoxicity given by these classes of drugs. There could be direct hepatotoxicity, hypersensitivity reactions, mitochondrial toxicity, which is the one that is very much associated with steatogenesis and with steatosis, immune reconstitution, inflammatory syndrome. And in many cases, there are many cases in which hepatotoxicity is dose-dependent, but in other cases is not actually dose-dependent, and the onset depends on the class of the medications. So, for example, for NRTIs, you can see here data for efavirenz and nevirapine that can cause hepatotoxicity. More is incidence is higher with the efavirenz, is higher with nevirapine than with efavirenz. And here is hepatotoxicity given by the NRTI. NRTI have been associated with lactic acid and fatty liver and acidosis syndrome. And there is a mitochondrial toxicity which actually induces steatosis and steatogenesis by changing the metabolism and inducing a high number of metabolic alteration. This results in hepatic steatosis. And there is an inhibition of mitochondrial polymerase which changes independence of the type of medication that we are talking about. Stavudine and didanosine are the medications which are more associated with hepatotoxicity in this class of drugs. And for the PIs, in this study by the group of Sulkowski, 300 HIV-positive patients initiated IP, you see that even in the co-infected individuals, just in a few cases, there was grade 3 or 4 hepatotoxicity, but in a significant number of patients, there were hepatotoxicity grade 1 and 2. So this is a summary of the ARV hepatotoxicity, and as you can see here, there is a red area in which we should pay more attention, like DDI, for example, stavudine, nevirapine, and tipranavir, while there are medications that are located in the green part of the graph. It's a summary slide to understand where the different type of ARV are collocated in terms of hepatotoxicity. So now the question is, we saw that transaminases are associated with chronic elevation of transaminases. So the question is this elevation of transaminases also translating in effective damaging to the liver? And the answer is yes. So there are a number of studies recently conducted which show that chronic elevation of transaminases in HIV mono-infected patients is actually inducing liver damage histologically. This study, published recently in CID, shows that if you have chronic elevation of transaminases in patients on antiretroviral therapy, there is 65% of patients who have significant liver pathology, and in 55% of cases, this significant clinical pathology is actually NASH. So it means that about over 50% of patients, HIV mono-infected with chronic elevation of transaminases on ARV have NASH, which is a non-alcoholic steatohepatitis. It's an evolutive chronic liver disease, which will eventually lead to cirrhosis and then stage complication. And NASH, in fact, you see also in 18% of cases, there was also bridging fibrosis. And in all cases, this was due to NASH. So NAFLD is a spectrum of disease. Non-alcoholic fatty liver disease is characterized by the presence of abnormal fat overload in the liver, more than 5% of the liver weight, associated with a non-significant alcohol intake. And this spectrum of disease encompasses two different clinical entities. One is fatty liver, simple fatty liver, which is benign, and generally it doesn't lead to cirrhosis and then stage complication. And about 1/3 of patients with non-alcoholic fatty liver disease have NASH, which is an evolutive clinical entity which eventually will turn in cirrhosis and complications. And it is characterized by the presence of fat into the liver associated with necroinflammatory modifications which will eventually progress. So the epidemiology of NAFLD and NASH in the Canadian general population in Western countries is actually the most common liver disease in Western countries. And the prevalence is about 20%, 20-25% in Canada, 70% in patients with diabetes, and 90% in obese population. So if you have patients with risk factors, this prevalence is extremely high. And NASH is less frequent, as we said, about 30%, 35% of patients. In Canada is range from 2 to 6% of the Canadian general population. But if you take a risk populations like diabetics, like patients with obesity, you see that the prevalence increases is much higher. So really my focus on my clinical research in the past year has been to demonstrate that HIV is not just me, but many other groups, that HIV is actually a risk factor also for non-alcoholic fatty liver disease and for non-alcoholic steatohepatitis, most importantly. As you see here, HIV is peculiar if you compare with the general population because there are specific risk factors which are not present in the general population, which include particularly the prolonged use of antiretroviral, which can cause metabolic alteration in a significant number of patients. As you know, insulin resistance is very frequent in patients which are HIV positive, and insulin resistance is the main driver in causing non-alcoholic steatohepatitis. And you may see, as you know, also an emerging prevalence of other metabolic risk factors given the aging population HIV positive. So which is the epidemiology in HIV positive patients on ARV? So HIV positive patients on ARV are at risk for steatosis, and we saw the data on the hepatotoxicity, and there are not many studies, and a number of them are also retrospective, but they strongly suggest that the prevalence of steatosis in HIV positive patients, even mono-infected, is much higher than the general Canadian population. About 30 to 40% reported, and if the patient is co-infected with hepatitis C, we go up to 70%. And liver fibrosis has been reported up to 17% of the cases in retrospective studies, which is more than 3-4 times higher than the prevalence in the general population. And non-alcoholic steatohepatitis, we have seen in recent data, show about 55% of patients with chronically elevated transaminase on ARV have non-alcoholic steatohepatitis. Which is the way to diagnose this condition in HIV-positive patients? Well, for such a frequent condition, biopsy is not the good tool because we cannot use biopsy as a screening tool, but there are a number of non-invasive tools which have been recently developed, which include Fibroscan, As you know, it's an ultrasonographic machine able to quantify fibrosis and also fatty liver through a specific software. Also, there are also biomarkers, for example, APRI and FIB4, which are simple biomarkers, Curtis was mentioning them, which can be used to rule out or rule in significant liver fibrosis, even though the accuracy of these biomarkers is lowest than the Fibroscan in recent head-to-head studies. And is HIV infection associated with higher fibrosis by these tools, by these non-invasive tools? And the answer is yes. In this study by the group of Jennifer Price, it was clearly shown by APRI that HIV mono-infected patients have a similar prevalence of significant liver fibrosis by APRI than the HCV mono-infected patients. So really, this is higher than the no-infection that you see, 0.3 versus 3.5, which is 10 times higher. And this is our study in which we showed in a longitudinal fashion what was the incidence of steatosis and on fibrosis in almost 800 HIV mono-infected patients with a cumulative incidence of fibrosis of 4% over a median period of 4.4 and a cumulative incidence of steatosis 24%. These figures are at least 2 or 3 times higher than those that we find in the general Canadian population. And the main factor associated with fibrosis was the presence of higher glucose. So again, metabolic risk factors do play a role in the development of liver fibrosis and non-alcoholic steatohepatitis and fatty liver in HIV-positive patients. This is a study from the group of Pineda, which used CAP, a software associated with Fibroscan to diagnose fatty liver. Again, 40% prevalence they found in HIV-positive patients, twice higher than the general Canadian population, and the major predictor, again, was a metabolic predictor, which is BMI. Our study, which we will present this afternoon, 300 HIV mono-infected patients unselected, so without elevation of transaminases, most of them on ARV, we found 48% prevalence of fatty liver. These are completely unselected. It was a part of a screening program, so there was no selection in terms of transaminases elevated of metabolic risk factors. It's extremely high. And in terms of prevalence of NASH, we used a biomarker, which is cytokeratin 18, is a biomarker of apoptosis, which has been suggested as a very promising biomarker by the American Association for the Study of the Liver guidelines. And we found a prevalence of NASH of 10%, which is 2 to 3 times higher than the general Canadian population once again. And these are the prevalence of significant liver fibrosis and cirrhosis that we found in 300 HIV mono-infected patients, completely unselected. Again, 15% with significant liver fibrosis. It's really a huge number. We were also ourselves very impressed by these numbers. Which were the cofactors associated with the steatosis and the multivariate analysis? Well, it was BMI, as other groups found, diabetes, and this is also very related to the pathogenesis of non-alcoholic steatohepatitis, and elevated ALT. And on the right-hand side, you see the difference that I put between the general population and the HIV mono-infected population on antiretrovirals in terms of prevalence of NAFLD, NASH, and liver fibrosis. You can see with your eyes it's at least double than the general population. So which intervention we can do in these patients? So we saw the huge number. It's really an epidemic that is coming out with the aging HIV-positive population. Which are the interventions that can be done? Well, they are similar to the interventions in some way that we do in the general NASH populations, and there could be also specific intervention related to HIV. Weight loss, optimization of glycemic control and dysmetabolism, treatment with vitamin E, and switch strategy. The last two, these are 2 strategies that I'm actually investigating specifically in the context of HIV infection. These are the guidelines for the American Association for the Study of the Liver, which recommended vitamin E as first-line pharmacotherapy in patients with non-alcoholic steatohepatitis, based on the results of the Prevalence study published in New England Journal of Medicine in 2010. And we are conducting a pilot study funded by the CTN, in which we are giving vitamin E to HIV mono-infected patients with a non-invasive diagnosis of NASH. And we already found in the first 10 cases, it's a pilot study, study, a significant decrease in terms of CK18, cytokeratin 18, so in terms of apoptosis, which is happening on the liver, which is a main event in non-alcoholic steatohepatitis, and also a reduction in the quantity of the fat of the liver. The other strategy that we are investigating is called switch strategy. Raltegravir, it's an integrase inhibitor, as you know very well, has a favorable hepatic safety profile, and it has also been shown to have a good metabolic profile. So the question that we were asking ourselves is a switch strategy a good treatment, a possible, feasible treatment for patients who have fatty liver, HIV positive, in order to reduce the quantity of the fat in the liver and to reduce the apoptosis related to the non-alcoholic steatohepatitis. As you know, the switch-MERC study, switch-MERC 1 and 2, both show that if you, in the raltegravir group, there were significant less elevation of cholesterol and of triglycerides, which are risk factors for non-alcoholic steatohepatitis and for fatty liver. So this is the switch-MERC study that we are conducting, in which basically we are using a control group without any treatment modification, and we are switching in the experimental group patients to raltegravir, and it's a study of 58 patients, and what we found is just pilot data, so it's just really up to 3 months from the switch. We already started seeing a reduction in terms of apoptosis that is happening into the liver, so in terms of inflammation and apoptosis related to possible non-alcoholic steatohepatitis. So in conclusion, liver disease, I think really it's evident, and there is more and more emerging literature, good quality literature, prospective studies, is a major cause of morbidity and mortality in HIV-positive patients in the post-ARV era, and not just in the co-infected patients, but also in the mono-infected patients. In fact, HIV mono-infection is at very high risk for NAFLD and NASH. It has to be considered a high-risk group, as diabetics or as obesity. We saw the numbers. Main predictors are metabolic risk factors and elevated transaminases. Early diagnosis of liver fibrosis and steatosis is essential to initiate intervention, which I just show you a few of them. Vitamin E, we are exploring. Switch strategy, we are exploring, but also weight loss, control of metabolic risk factors. And I think given the huge prevalence of this disease in HIV-positive population, we cannot use biopsy. We really need a non-invasive tool. If we don't do anything, I think this is an emerging cause of liver transplantation. In our center, for example, in 2000, there was no HIV-positive patients awaiting liver transplant, but now in 2005, last year, we already start seeing patients already transplanted or starting being on the liver transplant list. And they are patients also without HCV or HCV Co-infection. So thank you very much for your attention and for the kind invitation.
Good. So thank you very much, Giada, for reminding us that liver disease doesn't start and stop with hepatitis C in HIV. So thank you for sticking around. I know that was a lot of content. Hopefully everything was clear, but just in case you still have a couple of questions or things you want to clarify, now is the time to present your questions. You can either raise your hand and somebody will bring you a mic, or you can fill out one of the question cards and it'll find its way up here. In the meantime, I'll just remind you of the case to get us grounded in the clinically relevant things that we should be concerned about. It's a 45-year-old co-infected male, history of injection drug use, occasional alcohol use, on good antiretroviral therapy with a fully suppressed virus, genotype 1 infected with about stage 2 fibrosis, previously exposed to interferon, is on a number of medications, marijuana, proton pump inhibitor, antiretrovirals that are important to consider. So keep these questions in mind for the panel as well as the audience. What are the best direct-acting antiviral options for this patient? What are the drug-drug interaction concerns? What are the best fibrosis assessment modality? What are the reinfection risks? And are hepatitis C treatment outcomes really as good in the co-infected population? I mean, these are important for today's discussions. They're important for every single patient that we see in the clinic. These are the things that we need to consider before we can go forward. So having said that, are there any questions that you'd like to ask? Ooh, exciting. All right, so good point. We really focused on genotype 1 treatment. And most of the drug development, both in mono-infection and in co-infection, has really been focused on genotype 1. And the big reason for that, of course, is that most people in Canada are infected with genotype 1. But there are other genotypes, and in some cases, the options really lag behind. So I'll ask the panelists, maybe we'll start with Brian, to comment on other options for other genotypes and comment on upcoming pan-genotypic options that might become available.
Right, no, it's a very good point. I think it was genotype 1 and 4 actually that we focused on, but it really leaves us 2 and 3. For genotype 2, the combination of sofosbuvir and ribavirin produces success rates that exceed 90%. So there's a treatment that's readily available. In the Astral 2 study of sofosbuvir and velpatasvir, success rates that were well above 95% were achieved. So that would likely end up being the benchmark. We'll have to look at different costs of soft riba versus soft vel. Genotype 3 remains a little bit of an issue. Again, soft vel produces very good results in some of the less complicated, easier patients. Pan-genotypic options are coming. Two that I would just note is sofosbuvir, velpatasvir, and 9857, a new protease inhibitor, and the ABT493530 combination, which in vitro is probably the best against genotype 3. And for completeness, Merck has a triple of the Zepatir. Well, actually, it's not Zepatir. It's different kinds of combinations, let's say, of drugs that will become available in the coming years. So hope.
Sure. Giada.
Yeah.
Why vitamin E? How does it work?
How is it working, this thing? Yes. So, yes, vitamin E. The reason why, the story behind the Prevalence study is actually very interesting. This is the study which brought to the recommendation of vitamin E as first-line pharmacotherapy in the treatment of NASH. So vitamin E, as you know, is a potent antioxidant. And in the pathogenesis of NASH, oxidative stress is one of the, as a pivotal role, basically. When Prevalence study was designed, it was actually with there was 3 arms. It was pioglitazone, vitamin E, and placebo, if I remember correctly. And basically it was designed in order to demonstrate that pioglitazone was a good treatment for NASH. And finally it emerged that vitamin E, it was a little bit statistical analysis that the significance was set very, very conservative at 0.025 instead of 0.05, but basically vitamin E reached the significance while pioglitazone didn't. And that's why vitamin E became the first line recommended treatment for non-alcoholic steatohepatitis. So it's basically working as antioxidant, as potent antioxidant, which is one of the pathogenetic factors in non-alcoholic steatohepatitis.
Great, thanks. I think we have a question over there.
Nancy Sheehan from Montreal. So thank you to everyone. Thank you to Pierre for a very efficient talk on drug-drug interactions in 15 minutes. This is more of a comment concerning drug-drug interactions. I think PK interaction studies are one thing, but PK really doesn't tell us if these interactions are clinically relevant. In particular, with most of the DAAs, there's no relationship between PK concentrations and toxicity. Maybe the only exception is grasoprevir and ALT elevations. But even more importantly is that we don't know what's happening with intrahepatic concentrations. So the DAAs, to be active when we're looking at impact on efficacy, we have to not look at the plasma PK, but really what's in the cells, and obviously we can't do that very easily. So I think in this context, the only way we can really measure if there's clinically significant interactions will be with large database studies, like they did with lidopisvir and PPIs. I think we'll have to, work with people who do these big database studies like Tony Antonio, if he's here, to try to see if in the presence of inhibitors or in presence of inducers, if there's an actual change in efficacy.
Okay, thanks. So I agree with you. I've been telling Pierre that he's irrelevant for 20 years, but let's give Pierre a chance to defend himself.
It's my day-to-day work with Curtis. I think you highlight a very, very good point. I mean, what is the minimum? I mean, we're looking at pharmacokinetic interactions. What is the pharmacodynamic interactions? What does that mean in clinical practice? And I think that our job is going to get harder and harder as we get the success rate close to 99%, because to be able to see a difference in terms of serum concentrations or whatever factors, you need to have a fairly good significant number of failures. And I think that this is somewhat a limitation. On the other hand, the cohort can be indicative. I think that when you have many thousands of people in a cohort, it's good, but the data is never very, very clean. It can be a bit confounded by, as I said, confounding factors. So it's going to be quite complicated to tease out. But I agree with you. I mean, the question will be, are we looking at the right thing in terms of concentrations? Is it serum? Is it intracellular? And what are the real factors? Attached to this, I mean, the same question came about what is the optimal adherence for DAAs for SVR12, and I think you had clearly no answers to this question too, and I think it parallels what you just say with regards to how much is needed, right? So very, very good point.
Okay, great. Another question that came in on the card, and I'll alter it a little bit. But keep in mind that all of the current go-to options for genotype 1 treatment have an NS5A inhibitor. So what does that mean? The hepatitis C virus is made up of various chunks, and one of the key enzymes for the hepatitis C life cycle is this non-structural 5A. Each of the regimens, each of the DAA regimens have an NS5A inhibitor that inhibits that activity. So the Grazaprovir, Elbasvir is the NS5A, the Sofosbuvir, Ladipasvir is an NS5A, and then in the 3D regimen. So Brian, the question is, how, without going to a lab and evaluating somebody's blood to see, and their virus to see if there's resistance-associated variants or RAVs, how can we identify these people in the clinic? Is that possible?
Treatments are so successful that screening at baseline to see if there's pre-existing resistance is not going to be practical. The test might be useful to identify what to do next in the small number of individuals who do not respond to treatment, and that would presuppose that I would have an option available to deal with that information going forward, and that's still a bit of an evolving science.
So I'll play the devil's advocate, and also, there is some evidence that if you do have key baseline RAVs for NS5As, it does diminish the likelihood of success, probably only a couple of percent. It depends on the particular circumstances of the patient. But wouldn't you want to do that blood test and know for sure to give your patient the best option? So shouldn't we expect every clinic out there to be able to test for these?
Well, it isn't as clear-cut as in the field of HIV, where if you have, let's say, resistance to 3TC with an M1E4V, that the response rate is reliably diminished to such a point that the drug is not useful. So I think that's an important distinction to make. And there's no way ahead of time of just gleaning that information other than by doing the test. So it makes it a little bit tough. I think if the tests were widely available, were inexpensive, and were fast, that one could design a study to look at that and measure the cost effectiveness of testing everybody and selecting alternative treatment for those who test positive, as opposed to letting individuals all go on treatment and dealing with just that small proportion that don't respond. So there's arguments have been made a couple of different ways on that, and we're just going to have to see. As of right now in Canada, the test is available, though not necessarily easily, widely, or universally, let's say.
I mean, just to expand on the point you initially made, there's 300,000 people in Canada with hepatitis C. And there's a handful of clinics with the expertise to do these types of tests. We're supposed to be trying to make hepatitis C treatment easier, not harder. So we don't want to sacrifice capacity for complexity. We want more clinics out there who are able to deliver hepatitis C care. So,
Yeah, I agree.
any questions? So, Jad, I've got one for you. In the old days, if you had HIV and your liver was failing, forget it. You wouldn't even be considered in a Canadian transplant center for transplantation. Things are changing.
Yeah, exactly. So until exactly. So first of all, it was there were fears in the various transplant programs across Canada, but for the patient itself, let's say considered more fragile patient, but not just physically, but really psychologically, given that there is a high prevalence of relatively high prevalence of alcohol abuse, drug abuse, which are contraindication for liver transplant. Also just to be inserted in the liver transplant list, it was an issue. This has changed in the I know in the Toronto transplant program they are doing HIV positive infected patients, I think. But in our program we actually transplanted already, I think, 3 or 4 patients.
Yeah, there you go.
Most of them, all of them are at this point co-infected. So liver disease has been driven mostly by Hep C. But presently we have, I'm following myself, 2 patients who are HIV mono-infected patients with proven liver cirrhosis induced by NASH. So these are in the transplant list.
Yeah. So this is a really important and encouraging move forward in amongst the transplant centers.
Our center has been open to transplant HIV positive patients because it's really the only effective treatment for end-stage liver disease. So we are already transplanted 3 or 4 patients, and others are on the liver transplant list, including HIV mono-infected, which is my target.
This has been a success that's been a long time in achieving, and the credit goes to the healthcare providers and the HIV advocates who've been pushing this, trying to bring make it an evidence-based discussion.
Exactly.
And it's great to see that there's some success.
In fact, I also would like, coming back to the discussion that we were having on the DAAs, I think still there are some unanswered questions for our patients, and especially I think the data on the child C, patients with cirrhosis, child C are still not good. In fact, with most of the molecules. So given that they are actually the most fragile, co-infected or mono-infected, the ones who are really in urgent need for treatment, I think we need more solid data in child C cirrhosis.
Yeah, so just to in case you're not familiar with the Child-Pugh scoring system, once you're cirrhotic, you can get grouped into the Child-Pugh classifications. An A is somebody who has cirrhosis but no liver failure. B is a little bit of liver failure, and C is a lot of liver failure, just to understand that. And historically, you couldn't even consider starting a Child-Pugh B or C person on interferon-based therapies. Now with the direct-acting antivirals, there is emerging data with many of the combinations that it can be safely and successfully administered. Any more questions out there? Oh, Sharik.
Yes?
Better take a mic.
Hader from McMaster. I have a question that you may not have an answer to, but I'm just curious for the panel to comment on. So in the interferon era, at least for genotype 3, there was some data that if you treated steatosis prior to treatment of Geno 3, you improved your SVR rates. I'm thinking about the difficult to treat Geno 3 patients, and not the ones that Brian commented on that had 90% response rates. But is there any data out there that in the era of these new DAAs for the difficult to treat Geno 3s or even just other Hep C patients, given the prevalence you're telling us of steatosis, that treating steatosis first should impact on SVR rates?
Yeah. Well, at least
So-
with...
I'm
Did you
sorry,
want to start?
Curtis, I'm sorry.
I'll start and then you can give a better answer.
No,
So, I mean, there really is very little with the DAAs as far as looking at managing the steatosis before treating genotype 3s. So just so you know, with genotype 3, one of the curious characteristics of that is there's more steatosis in genotype 3 infected patients compared to the other genotypes. And it's been speculated that maybe that's why genotype 3s aren't responding as well to the DAAs. I don't know if that's actually the reason why genotype 3 patients aren't doing as well on the treatments. The DAAs that we currently have were discovered and developed in vitro in cell cultures based on genotype 1 virus. So it shouldn't surprise us that the DAAs work best in genotype 1s and not as good in genotype 3. I think with some of the newer second-generation regimens that are in development, in particular an ABV regimen, when you look at the small amount of drug that it takes to achieve full suppression, those look like those are drugs for genotype 3. And I think it's maybe the drugs probably the issue as opposed to genotype B3 being that much more difficult to treat. But I don't know. What you think, Giada?
Yeah, so I think we should, it's a very interesting comment actually, I find, because I think we have to distinguish two types of steatosis, in the sense that the steatosis that occurs in Geno 3, it's a viral-induced steatosis, while in steatosis that we find, it's common also in other genotypes, that we find in other genotypes, is not a viral-induced steatosis, but it's generally metabolic, so there are risk factors, these metabolic risk factors, diabetes or overweight or whatever. So the concept of treating steatosis before, I think it would be considered, and maybe it's an interesting, concept, but if it is not viral induced, because how you can treat viral induced steatosis just if you treat the virus. In fact, there are in the interferon area, there were reports showing that if you treat the Geno 3, then the steatosis disappears. And another interesting thing, it's that Geno 3, recent data also presented at the EASL and EASL, clearly show that they are the ones who are at higher risk of developing HCC, actually, hepatocellular carcinoma. So these patients, if you treat them, even if you achieve SVR, you have to, even more than the others, all the patients with cirrhosis or advanced fibrosis, you have to continue following them with screening for hepatocellular carcinoma, but especially if they are Geno 3, because they are a high risk for HCC. So I think it's a very interesting, different kind of steatosis.
Great, thanks. So I think it's time to wrap up. Just a couple of key points. In this day and age, the likelihood of achieving a cure and tolerating your therapy well is the same whether you have HIV or not. And so that gap has been bridged with the new therapies. So there's absolutely no reason not to consider it in our co-infected patients. It's important to have multidisciplinary services to offer our complex co-infected patients. It doesn't mean you have to have them all under your own roof, but develop networks of care that you can offer your patients to maximize the likelihood of success. And don't forget about the drug-drug interactions. They're critical to keep our patients safe when they're on treatment. And don't forget that liver disease and HIV doesn't just start and stop with hepatitis C. I'd like to thank our panelists for the expertise that they shared with us today. I'd like to again thank Merck for their generous support of this CAHR symposia. We couldn't do it without the support of our many sponsors. Thank you very much for sticking it out for an hour and a half. You stayed well beyond the lunch, so congratulations. And thank you. Enjoy the day.
Well done, sir. That was very, very